Agenda. Seeing none, Becky, if you would, please call the roll.
Senator Adams. Senator Byrd.
Present.
Senator Carroll.
Here.
Senator Douglas.
Present.
Senator Herron. Senator Mills.
Here.
Senator Nemes.
Present.
Senator Rawlings.
Present.
Senator Tishner. Vice Chair Richardson.
Here.
Chairman Meredith.
Present. Again, we do have a quorum, duly constituted to conduct business. A special shout out to Senator Byrd because she was on time and just she's a special gal. Yeah. We're going to have a slight deviation in our agenda. Two bills will be heard today. We're going to hear Senator Givens, Senate Bill 173. I think I see him hiding around the column over there. Senator, welcome to Health Services. Good to see you. I think you've done this a few times before, but just if you would, just identify yourself for the record and feel free to proceed.
Chairman Meredith and members of the committee, it's certainly an honor to be appearing before you for consideration of Senate Bill 173. I am State Senator David Givens, representing the 9th Senate District, and one of the early honors I had in serving in the legislature was to be a member of what was then the committee of, was it Health and Welfare?
Health and Family Services.
Health and Family Services, and certainly enjoyed my time there, and I'm excited to be before you today for consideration of Senate Bill 173. We do have a committee sub, Mr. Chairman.
Second.
Second. Say aye. Aye. Any opposition?
Mr. Chairman and members of the committee, Senate Bill 173 addresses something that has been vexing me for some period of time. When we talk about the state health plan, i.e. the contract that the state of Kentucky and all states have with federal CMS, I've long felt like it was a policy document. And as you know, the legislative branch is charged with the role of developing policy. So I'd long wondered why we weren't more involved in the conversation and the development and the execution, although the executive branch is charged with execution, overseeing that execution of that state health plan. And so began having considerations of, hey, let's just take it and write it. Let's be the policy-making branch that we are. Let's take total control. So in essence, what you've got in front of you doesn't go as far as I really wish it could. I wish we could actually do the entire development of the state health plan. But we really can't go that far because the volume of information needed is housed in the cabinet. And it's not surreptitiously housed in the cabinet. It's just by the nature of the role they play. The amount of information needed to fulfill the commitment of developing that plan is housed there. So I said, let's find some middle ground. And I started looking at what we do in regulations. And that's why you have the sub in front of you. The initial draft of the legislation was for us to approve the state health plan. Received some letters. In fact, it sort of made me feel like maybe we were onto something when we started getting letters. I received letters from Secretary Stack, as well as letter from the Office of the Governor indicating that we don't have authority to approve the state health plan. Suddenly, when you start getting these sort of letters, you start to think maybe we're doing something. Maybe we're striking a nerve in some way. And I do think General Counsel Mayo is correct in the fact that we don't have authority to approve, but we have authority to disapprove, as we see with regulations. So the process laid out in Senate Bill 173 is very similar to the administrative regs process. It indicates that the legislative body, the policy-making entity for the Commonwealth, will be involved in reviewing the state health plan. State plan amendments will be reviewed by this body, not for the purpose of approving, but for the purpose of considering how it fits in the fold of the policy we're developing. And then we have the authority to find those plans or components of those plans deficient, just like we do with regulations. So it follows a very similar process in that regard. Now, the last thought I'd like to share with you, or the last few thoughts I'd like to share before I consider any questions the committee may have, goes to what I call the tipping point moment of the genesis of this legislation. In appropriations and revenue, as we were hearing the presentation from Budget Director Hicks, I'm going to stagger you with some information that he provided. This was the tipping point of why we've got to be involved. In Frankfurt, it's easy. Over the years, I still find myself doing this, thinking that things fall into silos that really aren't connected to each other. It's the nature of what we do. We think, fixate on this question or this issue, and if we fix that issue, it's going to fix the issue. Everything is so interconnected. The state health plan, when we talk about MCO profits, it's connected. When we talk about our Medicaid population, as I'm going to indicate to you in just a moment, it's connected. But the tipping point for me was Budget Director Hicks in his presentation indicates that in 2028, enrollment in the Medicaid program will be reduced by 28,539 participants, reducing the population of Kentuckians that are covered by Medicaid by 28,539 individuals. But the cost of Medicaid in 2028 will be $2 billion more than our current enacted budget. We're covering fewer people and it's costing astronomically more. Something is out of balance. Years ago, when we were wrestling with pensions being out of balance, we developed PPOB, Public Pension Oversight Board, and started sending so many pieces of legislation and so many policy ideas through that filter to try to better understand it. Senate Bill 173 does a similar thing. It uses the regulatory model that we've got and have long had the authority to do of finding regs deficient, and it sends it through MOAB, a new tool that we as policymakers have at our access, and I'm excited about the policy and the legislation. We'll be glad to entertain any questions.
Thank you, Senator. And I think what you're proposing is kind of a natural progression of what we're doing, particularly with the Medicaid Oversight and Advisory Board. I think that's one of the best pieces of legislation we passed in several years, and certainly has given us an opportunity to do an intrinsic review of that program. And we know the changes have to be made, so I think you're so correct that we can't live and work in silos as we have in the past. And while Medicaid oversight is just one component of our state health plan, anything that happens to state health plan impacts the Medicaid program. So this certainly makes sense to me. Any questions from committee members? Senator Byrd.
Thank you, Mr. Chairman, and thank you, sir. Will legislation affecting Medicare and Medicaid automatically be sent to MOAB like it is to PPOB? Because it does not seem like we're doing that this session.
Excellent question, Senator, and I'm gonna ask you to take one word out of your question, the automatic piece. And the reason I say take the automatic piece out is we don't have in rule that it has to do that. But we do have in practice. I share that with you to say we've had multiple conversations. We had multiple conversations in leadership on our side about almost every piece of legislation that touches Medicaid and said, hey, has it been through MOAB? Now, we may have missed one or two, but if you could see the heads behind you nodding, they're realizing now, and as I am, and I don't file a lot of Medicaid legislation, but these conversations going through MOAB are happening. They're not automatic, but they're intended to happen regularly.
Follow-up, sir?
Yes, please.
Are they automatic for PPOB? And is there a reason that we haven't done it this session?
My understanding is there is nothing written, and I could be corrected, there's nothing written in rule that something has to go through PPOB. I look to Leader Mills to see if we have anything written in rule. No. But we do by practice send it through PPOB, and it is our intent to send these pieces related to Medicaid through MOAB.
And that practice you reference is our employee pension program. And that certainly is a kind of a standard practice we follow now, that any changes that goes to that committee for review.
Right.
Obviously, the pension committee nor Medicaid oversight can take formal action on those things, but it makes us informed and we can make recommendations. So I think that certainly makes sense. Senator Rawlings, you have a question?
No,
Okay.
Nemus did the motion and I did the second.
Okay, then there is a motion second. If there are no other questions or comments? Seeing none, Betty, please call the roll.
Senator Rocky Adams.
Aye.
Senator Byrd.
Explain my hesitant I vote.
It still counts as an aye vote, though, doesn't it?
Honestly, I think this is a very, very, very big bite to chew off. I'm not saying it's not necessary, but I would strongly warn people that we have the expertise in the executive branch that we do not have in the legislative branch. And honestly, the legislative branch's understanding of our healthcare delivery system is limited. Even my understanding is limited, and I have been participating in it for almost my entire life. So I'm really concerned that we are taking people. I mean, remember, guys, the person who is running our health services, our cabinet, is past president of the American Medical Association. The woman who is in charge of our Medicaid and Medicare compliance is considered one of the top knowledgeable officials in the country on the subject. I mean, you go and you ask, and everybody knows her. Everybody admires her. So, we don't have that. We do not have that. And to assume that we do, in my opinion, is hubris. So I will very hesitantly vote yes to see where this goes, but I will say I have a lot of concerns. Thank you.
Senator Carroll.
Aye.
Senator Douglas.
Aye, but explain my vote.
Yes, please.
Thank you, Mr. Chairman. One of the things I'd like to say is a leader is only as good as the consultants that he or she consult. And I think this is a good bill, and I want to thank the senator for bringing it this morning, Mr. Chairman. Thank you.
Senator Herron. Senator Mills.
Explain my yes vote.
Yes, please.
Thank you, Mr. Chairman. I think this is a very good bill, and I think we can just go back just a few days ago when they were considering adding the GLP-1 drugs to Medicaid coverage. That would have been explosive to our costs of Medicaid. And there are many, many, many decisions that are made like that we need to have oversight and need to form our opinion around and object when we think it's going to cause our budget to have the wheels fall off. So thank you.
Senator Nemus.
Aye.
Senator Rawlings.
Aye.
Senator Richardson. Senator Tishner. Chairman Meredith.
Aye. Vote is unanimous. And bill passes favorable expression. And Senator, appreciate you bringing this before our committee.
Chairman and each of you members, thank you for your vote and your support. Thanks.
You're certainly welcome to stay for the rest of our committee meeting if you would like.
Thank you, sir. I'd be honored, but the work is too heavy in this committee. It's just too heavy.
Next bill is my own, Senate Bill 137. I'll ask Co-Chair Richardson to assume the chair.
So assume, Mr. Chairman. Thank you. Steve, do you have anybody with you? You can have anybody with you?
Yeah.
Okay. The chairman knows this is probably my favorite part, to ask him to please introduce himself, but also to the guest up there, double check your light is on, lit up green, and individually introduce yourself by name as well.
Morning, Mr. Chair. I'm Steve Meredith. I'm the State Senator for the 5th District of Kentucky.
Good morning, Senators. I am Joshua Reynolds. I'm a policy analyst for Cicero Action.
Good morning, Adam Meyer from Cicero Action.
Good morning, Dr. Erica Gregonis from Baptist Health Richmond.
Appreciate the opportunity to present Senate Bill 137 to you this morning. And what we're attempting to do is address a problem that is serious, will become more serious in the future. It's projected by 2030 that we're going to have a shortage of almost 3,000 physicians in the state of Kentucky. And already that shortage is quite pronounced in rural communities where we know 42% of our population exists, but only 17% of our primary care physicians are there. And a lot of our work on the Medicaid Oversight and Advisory Board has focused upon the need for additional physicians if we're going to truly improve the health of the population. That's where the opportunity for the most significant savings are for that program. And I remind you again, our Medicaid budget has grown from $10 billion in 2017 to over $20 billion during that short period. So we have to wrap our arms around this. In the first place has to be enough practitioners that people have access to care. And specifically primary care, that number I gave you, I think the primary care shortage is more like close to 700 by 2030. So this is a measure we hope will address that. It's not the total solution to the problem, but it's a big step in the right direction. With that, I'll turn it over to my guest.
Morning again, Adam Meyer from Cicero Action. I'm the Health Policy Director at Cicero Action, where we focus on state policy and we advocate for entrepreneurial solutions to public policy problems. I'm also a Kentuckian. We've pushed this legislation, of course, in probably dozens of states by now, and it's passed in close to 20, I think. But as a Kentuckian, I don't want us to be left behind. And so having formerly run the Department or the Cabinet for Health and Family Services, I know how important this issue is and the workforce shortage that we face. So joining me here today is a colleague of mine, Joshua Reynolds, and he's going to walk through the key elements of the bill.
Mr. Chair, before we proceed, my apologies, but there is a committee sub.
Second.
All those in favor? Please say
Thank you.
adopted.
Okay. Thank you, committee, for your time. Following up on what the sponsor mentioned with the physician shortage projected for Kentucky, getting deeper into the weeds, the projected physician shortage for primary care physicians specifically, who provide the most essential backbone care for patients, is 624 PCPs. And there are dozens of counties in Kentucky that are currently designated as health professional shortage areas, including 38 that are fully designated as HPSAs, meaning the entire county is a shortage area. That affects 1,752,000 Kentucky citizens who live in one of these health professional shortage areas. Over the last 5 years, international medical graduates filled 237 of Kentucky's available residency slots. That accounts for about 12% of the residency slots in Kentucky. Many of these physicians did not need to repeat postgraduate education, and allowing these internationally trained physicians who have already completed residency and worked for a number of years in their country of licensing will allow them to immediately address the physician shortage in Kentucky and open up more of these slots for U.S. medical graduates. This is important because there's a limited number of slots, and over the last 5 years, Kentucky has filled more than 90% of these positions each year. Under the current law, Kentucky requires international physicians to complete residency in the U.S. regardless of their previous passage of a residency, but Senate Bill 137 removes this duplicative requirement and provides an immediate answer to the healthcare access challenges that Kentucky citizens face. A number of other states have already taken action, as my colleague mentioned, including Kentucky's neighbors Tennessee, Illinois, and Virginia, which have all passed robust pathways in the last few years. In Illinois, there are 20 pending applications with employment offers, and 172 physicians have started the process by seeking sponsorship. So this does provide a meaningful impact on the supply of physicians in the state. Lastly, there are another 10 states approximately that are currently considering bills on this very topic. So we could see the number of states that have created this pathway swell from roughly 20 to nearly 30 if these all go through. One last point to bring up with respect to residency in Kentucky, nearly half, 49.2% of those who complete residency in Kentucky go on to practice out of state. We need physicians that will practice in Kentucky now, and this bill will allow for international physicians to come to work and serve Kentucky patients at the highest level of their training. There's a lot of safeguards that are already built into this bill to ensure that this is only increasing access to care and in no way detrimental to the existing quality of care that Kentucky citizens expect. This includes English proficiency requirements, graduation from a foreign medical school and completion of a foreign residency program, or alternatively, graduation from a U.S. medical school and completion of a foreign residency program. At least 5 years of work experience as a physician, fully licensed in their country of licensing, in good standing with the licensing authority of that country. The certification by the Educational Commission for Foreign Medical Graduates, passage of exams required by the Kentucky Board, and lastly, an employment offer from a sponsor. This last point is significant because the hospitals are going to use good judgment in who they determine fit to practice in their facilities. No facility wants to take on a doctor that's going to present health liabilities to patients and increase their insurance costs. Thank you very much for your time, and I strongly and respectfully urge your support of this bill.
Thank you. Good morning again. Thank you, Mr. Chairman and committee, for being willing to give me a few minutes to give my perspective as a practicing physician. My current role is I'm the Chief Medical Officer at Baptist Health in Richmond. I'm also a practicing pulmonologist and intensivist. So Baptist is the largest healthcare system here in the state of Kentucky. We have multiple hospitals. We don't just have hospitals in Lexington and Louisville. We have hospitals in LaGrange. We have hospitals in Richmond, where I work, Corbin, Paducah, Madisonville. We have multiple rural facilities, and that's a very different recruitment obstacle versus Lexington and Louisville. Baptist currently is recruiting for over 169 physicians. That's actually better than what we were previously, but it does present a challenge. This bill helps tackle that in a small way. I think one of the things that we need to think about is this is not a Kentucky problem, this is a national problem. I think you've given some really great statistics about the physician shortage. Nationally, the expectation is us to be at a physician deficit or a shortage of over 86,000 physicians by 2036. That is a multifactorial problem. One, we have an aging population creating more demand. We also have an aging physician population. Over 40% of physicians in this country are over the age of 55. We also have limited training spots, which I think you went into quite well. I think one of the things that we have to remember, to your point, I think 12% in the state, nationally 25% of our training spots are taken by international medical physicians. I think, once again, they're already coming here. They are already training, but often this is redundant training. I think I can give some very good examples of, just my experience in medicine. I work with a GI physician. He was a colorectal surgeon in his primary country. He chose not to go back through that rigorous training that was so extensive. It wasn't worth it for him. I have a nephrologist I work with. He was a cardiothoracic surgeon in his home country. When I trained during residency, one of my residents had been an interventional cardiologist for 12 years. I can't tell you how many times during rounds our interventional cardiologist would come out and ask him his opinion as he was an intern. We are really wasting one of our most valuable assets in this country, fully trained physicians. When we are done, when I got done with my training, I was mid-30s. You think about that, we only have so long to work. If we're asking them to repeat training that is redundant, we are wasting that very valuable asset. I think these are things that we all need to think about. I think you brought up the fact that we are going to sponsor them. We will have safeguards in place. We would be recruiting them. We would also be mentoring them and making sure that they really are able to integrate into the rural areas. Our goal is for them to want to continue to practice in those areas. Currently, most people will stay quite frequently near where they train. And if this is only open to academic institutions, these physicians are probably going to stay in Lexington and Louisville and never reach the rural areas where I have practiced my whole life. this is where we need the physicians the most. So I just really ask for you to consider this bill. Thank you.
If I may, Mr. Chair, just a couple other things to add. I just want to point out this is not a zero-sum game, right? We're not, by passing this, you're not essentially trading international trained physicians, IMGs, for domestically trained, right? We have a shortage that's been clearly articulated, but these residency slots are finite. And so for every time we fill a residency slot with an IMG who's already had residency, who's already completed residency, we're taking that slot away from a domestically trained physician who could fill that, and maybe it may not otherwise match, right? So it does really increase the supply in a way that's really leveraging our finite resources better. We should also not be concerned about quality. We obviously want to be concerned about quality and safety, but in the studies I've looked at, IMGs have performed equal to or even outperformed domestically trained. There was a study in Pennsylvania that looked at over 250,000, I think, patient discharges, and found that the mortality rate was lowered by 9% in IMGs versus domestically trained. So there are really good training programs out there around not just in our country, but around the world. And so we need to recognize that there is talent everywhere. And, when we're talking about increasing access to rural areas, to underserved areas, it's also typical in Kentucky too, that there's a higher percentage of IMGs in these rural or underserved areas than there are as allocated than there are domestically trained. So they really can help fill a gap that we need and a void that we need.
I think I will add one more thing to that as well. If you want to talk about quality, that's something that is at the forefront from all of medicine. It's not just whether or not they are internationally trained or not. We have quality programs. We have peer review processes on all physicians. Anytime there's a new physician onboarded, doesn't matter where they trained, we're going to do that same process. We have what we call ongoing professional evaluations, and we literally audit new physicians and look at cases and look at notes, just to once again make sure that we continue to have that great quality care that Kentuckians actually deserve.
Before we get there, we do have one question. I do want to remind everybody we are doing fantastic on time, so let's keep it that way. Senator Byrd, questions?
Good morning. I will thank you very much. I will try to be very brief. It's really sort of three questions in one. How do you document primary verification? Because that's something that's required in this country. How do we do it? What exams are required to be passed? And I know you say you have adequate oversight. What oversight is built in to the bill? And let me tell you guys, my experience has been very positive at the university with foreign medical graduates, the majority of whom that I know personally came from Germany, extremely well trained. They didn't all do well in this country, I'll be honest. I think out of the three that I worked with, two of them are no longer here. And then my last question, the $100,000 that we're going to now have to pay, who pays that?
As far as the tests are concerned, they're going to be taking the same exact exams that are required. USMLE.
Microphone, Senator Burke.
Yeah, it's the USMLE, I think is what is prescribed. And then they also have to be ACFMG certified, Education Commission on Foreign Medical Graduates. So that looks at the quality of their training and their education. It also
Medical school, not
correct.
That doesn't do advanced training.
But it does require they take some additional competencies, right? So they have to demonstrate, for example, English competency during that process. So there are some things that are built into that ECFMG process as well.
Okay. Oversight?
Oversight. I think like anyone, we would probably have a mentor process in place. And to your point, I get that. We have to make sure that we help them translate to being into this country. And
Required in the bill? Required. Oversight is required. Mm-hmm. Thank you. Okay. Thank you. Thank you. Thank you.
Thank you, Senator Bergs.
Oh, the $100,000, guys. That's a new federal thing. Yeah.
Thank you. Senator Titchener.
You don't know?
Thank you. I have some concerns with this bill. based on a perspective that I bring, I lived for 4 years in a third world developing country. I delivered a baby in a third world developing country. My doctor was a foreigner. She was German. She did a great job. I also had some dental work done in that foreign country. They were nationals. It led to me having to have surgery in the United States. So I have concerns about that. One of the things that concerns me, not necessarily, is the quality of care that may be coming from someone foreign trained. I have both perspectives there. I had a German doctor, did a tremendous job. It's more the concern of the opportunity for developing countries, doctors coming from certain countries that don't have the high standard of medical licensing, and the potential for false licenses to be offered. There was a story that just broke at the beginning of this month in India, where 100,000 medical, nursing, and engineering degrees were given out fraudulently. That's a big concern to me. And it's, again, you'll find great doctors in developing countries as well, but the opportunity for fraud exists where there's corrupt government, bureaucracy that's fed by corruption, and I've experienced that. So those are some concerns I have. Can you all speak to any of those concerns and how, what you've put into place, how that, any safeguards you've put into place to address those issues that could make me vote yes on this bill?
Sure, I can give a little bit of perspective from Baptist. Several years ago, we actually started doing what we called centralized credentialing, to where we do primary source verification, and we have to get primary source verification from their home country. I actually, as a chief medical officer, have to look through those files quite frequently, and there's many times I may see 10 different verifications. But we do put a lot of safeguards in place because of that. We know we want to make sure that their file is up to snuff. I think one of the things you were alluding to of like, how do we make sure that things are the same? I think once again having that mentor program, and I think also from a Baptist perspective, I work for a great organization that we do a really good job of making sure people are oriented to our mission, vision, and values. And we always say the most important words in our mission statement are demonstrating that love of Christ, and really showing how that is the most important thing to us, is treating our patients how we would want to be treated.
And I would just add, I mentioned earlier, the Education Commission on Foreign Medical Graduates does do some vetting on these foreign medical schools, right? So they're looking at the schools, the curriculum, and they're also looking at those individuals through that process. And then you also have the additional safeguards. They still have to pass our medical exam, right? So they still have to demonstrate the competency to basically the same requirements that a U.S. trained physician. The only difference here is that they don't have to repeat residency, and in its place they've had to demonstrate that they have practiced for 5 years in their country of licensure.
And this is radically different from just filling out a job application and wanting to go to work.
Yeah.
Credentialing is a very structured process. And bear in mind that no provider wants to expose himself from a professional liability standpoint, and they're not going to take shortcuts. It doesn't make sense to do that. Very interested in your experience with physicians from Germany. That didn't work out because it's interesting. In my small community, I worked with physicians from Pakistan, Canada, Lebanon, India, and even Iran. And they were great physicians that wanted to be here and ingrained themselves in our community, and major contributors. And I think that's the big difference, is you're going to get physicians who want to come here for the quality of life that we offer and the freedoms that we offer. And they make good additions to our medical staff in our community.
Senator Carroll.
Thank you, Mr. Chairman. And Senator Meredith just kind of reinforced what I was about to say through personal experience at Baptist Health Paducah. My daughter had some pretty serious gastro issues recently. Talk about her becoming septic. I fly home, get there. There were some problems, not with the doctor, but when I heard it was a doctor from India, I had concerns. And that young man won me over quickly. He stayed up all night monitoring her numbers, adjusting her IV. He spent time to talk with my wife and I. And I've never experienced that level of care. And you could tell that he was honored to be there. And I think he was in Paducah due to a rural health program, because he actually lived in Chicago and he would come down and cover weekends. and he communicated with the gastro practice routinely, and just great care. And he won me over completely, and just a great young man. And I tried to convince him to move to West Kentucky. A little bit of culture shock from India to Chicago to West Kentucky, but hopefully he will stay. And the young man did a great job, and I couldn't have had a better experience with that foreign physician. Thank you, Mr. Chairman.
Thank you. Senator Hare.
Thank you, Mr. Chair. Thank you all for this bill. Kind of similar to what the previous senator spoke about. One of the questions that I have is that when we're talking about bringing folks from other countries and bringing them to our rural communities, there may be some prejudice or thoughts from patients, but then also other employees. What is going to be put into place to make sure that there's training around culture competency, and then just to integrate them, into the structure, to make sure that they are not being treated unfairly or different from patients and or their other coworkers that they would be working with. And so what would that training look like for both sides, the employees who are already employed there, and then also the new physicians coming in?
I appreciate that question. Let me share a personal experience with you. As a former hospital CEO, I became CEO in 1983, and we had a contract service for our ER physician coverage, which most hospitals had. And I was asked the question, they were recruiting, the company we worked with was recruiting physicians to come to our ER. And most of them didn't live there, they just came in to work, and then we would leave after the shift is over. And one of the questions they posed to me is, we got a really good doctor, but he's African American. Well, that posed a problem. And I was really shocked by that question, because my home community were 95% white. And I said, no, that's not a problem at all. As long as they're a caring physician, they can relate to the community, it's not a problem. And I can tell you, he ended up being one of the most popular ER physicians that I ever had in my hospital. I mentioned the physicians that we recruited from these other foreign countries, well received. You know, there's a saying that people don't care how much you know until they know how much you care. And every one of these doctors that came here cared about their patients. And it's like our community wraps their arms around these people because they wanted to be successful, they wanted to contribute. So part of living in that community helps orient them to the community. And we'll go out of our way to make sure they do. But also the other members of the medical staff will reach out, particularly small medical staffs, to make sure that physician is successful. And they'll help with that cultural change and also just indoctrination to our culture and to the practices of medicine in the United States. So I don't know that you've got to have a formal program in place, because most physicians coming here know what the expectations are, and we readily embrace them because we need them.
I would just add that this is not new. 1 in 5 physicians in Kentucky workforce are IMGs, right? So they're already an existing strong part of our physician workforce. They demonstrate competency, they build confidence that way, right? They showed their peers that they can perform the same as people who are trained here, right? And I think that goes a long way to dispelling any issues. And I'll let Baptist speak to kind of what it looks like in practice.
Sure. I was actually going to say that. I think we're probably very similar to others. When we onboard a physician, whether, no matter where they trained, we actually have regular check-in meetings with them. And that is literally one of the questions that we ask. How are you integrating into this city? How are you being treated? Are there things that we need to do to help you? So those things are getting addressed. We give them that opportunity to let us know. So that way, if there is anything going on, we can help fix that.
Thank you. I think we already had a motion, Senator Mills, and a second by Senator Nemes. All right. We'll go ahead and go roll call.
Senator Rocky Adams.
Aye.
Senator Berg.
Aye.
Senator Carroll.
Aye.
Senator Douglas.
Aye, but I'd like to explain my vote, Mr. Chairman. Okay. Let's just keep in mind that all the foreign medical graduates that we're talking about that are doing all these wonderful things are people who've had to come to the United States and participate in a residency. Let's not all of them, most of them, but let's not forget that. Okay. I do have a question. Why 20 to 25% of our education slots are being given to graduates of foreign medical colleges? I think that's an academic question, and I think that's a financial question that sometimes our medical schools that we support here in the Commonwealth need to answer. Right? There's no lack of applicants, so I'll look into that, and I really, really, really appreciate that. That should not be happening. You know, I obviously I've already voted for the bill. I'm always concerned about bringing in new physicians or allowing physicians to come in and us using the suggestion that they're going to go to our healthcare professional shortage areas. It doesn't necessarily add up, and usually doesn't add up. But I think that we need to allow the bigger picture in terms of more people in the General Assembly to get an opportunity to get a bite of this apple and get comfortable with a bill such as this. So I'm voting yes because I want this bill to go ahead and move on. Thank you very much, Mr. Chairman.
Senator Herron.
I'm a yes. Can I explain my vote, please?
Yes.
Yeah, I'm a yes. I'm excited about this bill, but I do think that it is going to be important to make sure that there's something built in for implicit bias training or diversity training. I mean, we just heard from Senator Carroll about his experience dealing with a doctor from India, and it's not that people are doing things on purpose. That's just who we are as humans. And so I would just highly suggest that there is something built in to make sure that the other employees have what they need, but then also the physicians have what they need. Thank you.
Senator Mills.
Aye.
Senator Nemes.
Aye.
Senator Rawlings.
Aye, but I'd like to make a comment. So
Go ahead.
my wife gave her kidney to her brother last year and gave him new life. And the surgeon in the transplant unit at UK was from Venezuela. And he was just excellent surgeon and kind and caring and did just a fabulous job. So we were just very impressed with that. So that made a little impact on me on the vote today.
Senator Richardson.
Aye.
Senator Tishner.
Explain my vote, please. I'm still not comfortable with this bill. I'm going to be a no on this bill. I think we've had a good discussion, brings up some great points. I think adding a few things to the bill would be helpful. I think one of the most concerning things Senator Douglas touched on is that we have applicants. We have students who want to get into medical school, and the need exists currently for doctors, but we're not allowing those slots to go to American citizens. We're allowing foreigners to come in and take those slots, and I think that's something to look at, and that makes me think about are they not being accepted because they don't have a great application? Do we need to strengthen our education system so that we're funneling more students into the field of medicine? I think that would be a great place to look at. Still just have some concerns based on my experience, but I do appreciate your all's efforts and your work, and I understand the need exists that we need to address still. Thank you.
Chairman Meredith.
All right, I'd like to explain my vote. Just remind folks again to Senator Douglas and Senator Tishner's point is because of the passage of this bill, we're not taking a residency slot. We're actually opening up a residency slot. And just yesterday, President Stivers announced that he's asking University of Louisville, University of Kentucky, and Pikeville, also East Kentucky University, to look at the whole process of bringing physicians to this state. And I'm sure this is going to be one of the issues that we would talk about is should our residency slots be reserved first for Kentuckians? And so I think that's going to be addressed, but this is kind of a separate issue from this. But again, this protects those residency slots and provides us with well-qualified physicians to fill roles that are desperately needed. So thank you, Mr. Chair.
Senator Berg, do you have a question or comment?
Just take 1 second to explain my yes vote. My one concern, guys, is that, as a diagnostic radiologist, you get to see who knows what the heck they're doing and who doesn't, and who has good outcomes and who doesn't. And the one worry I have is that in some places, your most beloved physicians are your most dangerous. Patients don't know what good quality health care actually is because they don't know. And that is my one worry. That's my one worry. Thank you.
Mr. Chair, if I could speak to that.
Go ahead.
You know, there's an old joke is, what do you call the person who finishes last in medical school? Doctor. And there are as many bad American-trained physicians as there are foreign-trained physicians. And the real litmus test comes from the actual care of the patients. You find out very quickly what they're like. But I do acknowledge your point that, yeah, some of the most popular are not the best, but that's pretty much life. That's not specific to the medical community. But thank you, Mr. Chair.
Okay, thank you. Bill passes 10-1, 10 aye votes, 1 nay votes. The Senate Bill 137, as amended by Senate Committee Sub 1, has passed with favorable expression. Before we move on, is there anyone that needs to cast a vote for Senate Bill 173? Excuse me. Yep, 173. Okay, we're good. The next piece of business is adjournment. Before we get there, the next meeting is today upon adjournment of the Senate here in room 129. Noted. Senator Herron is a boo. Do we have a motion for adjournment?